2, 1. Hey, gang, it's Gonzo Gonzalez, and you're listening to Dr. Gonzo's Talking Points. And today I thought that for something a little bit different, I wanted to invite a friend of mine to talk about a not so uncommon condition that relates to the heart, and that's a condition called endocarditis. Now, what I've done is invited, as I mentioned, a good friend of mine. His name is Cedric Spak, Dr. Cedric Spak from Tarrant County Infectious Disease. And what Cedric does is that he's a doctor that specializes in infections. And so you can imagine an infection can occur anywhere in the body. But what Cedric is good at and has developed a really good career in doing is basically taking care of patients that have infections associated to the heart. And you would think that that's a rare thing that happens. But the type of patients that Cedric and I handle on a day in and day out basis are these individuals that have infections that they've acquired by a number of things. And so what I thought it would be good for the public to sort of listen to is how this disease occurs and basically evolves from the time of acquiring it to what it could do to your heart and how do you manage it. So Cedric, thanks again for joining, and I really do appreciate taking time from your schedule to come in and do this interview.
My pleasure, Gonzo. It's good to be here.
So listen, before we jump into serious, so I understand from you and I talking that your kids are pretty social media savvy.
They are.
How old are they?
I got 2 teenage boys and a middle school girl.
Are they going to be listening to the podcast after we publish it?
I actually will tell them, and it's always a mystery whether or not what I do will be interesting to them or not. I think it'll be interesting, so I'm excited to share it with them.
Okay, I'm going to tell you a story before we jump into the discussion, but this is something that I saw on TV once. So you know Sting, right?
Of course.
Okay, so Sting was actually at the Grammys one year, and he brought in one of his teenage children. I think it was a teenage girl that he has. And when he was getting interviewed, they asked him point blank, so who's this? And, he answers, oh, this is my daughter. Her name is, and I forget her name. And then he proceeds to say, they ask him, so why'd you bring her? And he says, well, I just brought her in because I wanted her to see that her dad is really cool. And I was like, what do you mean that your dad's cool? You're Sting. So in any case, I hope that when they listen to you, and what are their names? I just want to say a shout out to the Spot kids.
So it's John Paul, Joseph, and Ava.
Okay, so John Paul, Joseph, and Ava. Your dad is really cool, and let me tell you, there are very few people in medicine that I can consider experts, and your dad is one of the experts, so you should be very proud of what your dad does. So if you're listening and tuning in, this is the reality. Dad's super cool, and he's one of the smartest guys that I know. So hopefully they're listening. And, no problem. So listen, okay, so let's jump into it. So let's talk about endocarditis. Okay, so you and I on a day in and day out basis get consulted about these patients that have the condition called endocarditis. So for the listeners, tell them what endocarditis is.
Endocarditis is an infection within the heart valves. And the heart valves are the part of the heart that keeps the blood flowing in the right directions. When endocarditis happens, it can often be a surprise to doctors. It can be difficult to diagnose, and it usually needs a team of doctors to really establish the diagnosis.
So infection in the heart, it typically affects the valves, okay? And as you well know, and Cedric is actually in Fort Worth as well, as I mentioned at the beginning of the show. And so, Cedric and I work closely together, and because he is also part of the valve program in Fort Worth that we've been talking about over the last few weeks, Cedric does have a very in-depth insight as to what this disease is. So, but how can you get it? So if somebody asks you, Doc, how can I get this infection in my heart?
Well, usually what happens when an infection in the heart valve occurs is that the patient has to have bacteria that are circulating in the blood. And it has to be a large amount of bacteria. And bacteria can come from many different places, but once they get into the bloodstream, they can actually attach to the heart valve if it's the right kind of bacteria.
Okay, so who's at risk?
The risk depends on a lot of things. 50 years ago, we talked about endocarditis as being something that was a risk for people who had previous heart issues, usually some sort of a murmur or abnormal heart valve that they had acquired, usually at birth. And now, 50 years later, it's a little different. Endocarditis, the disease, changed as human behavior has changed, so that different people can actually get the infection.
So how's it different from what it was 20 years ago then? So you
Well,
said behavior. So what things have changed to make it that different?
Well, the thing that really has changed the most is the use of polysubstance abuse, heroin, cocaine, methamphetamine. When young people end up using these kinds of substances, and if they're injecting them into their bloodstream, every single time they inject in their bloodstream, they're introducing a traumatic event that actually will go through all of the bloodstream and affect the heart.
Okay. Now, let me ask you a question, because this is something that we all do, okay, and I do, and I have to admit. But has the common use of prescribed antibiotics, like say, this is something that we just went through, the flu season. We're at the tail end of it, but it's a common thing that everybody asks for, and it's the use of Z-Pak, the antibiotic that we prescribe for people that have flu. And after a certain time, if I know people that they start having symptoms and don't get over the cold or their flu over, a period of time, then they ask for a Z-Pak. How's that changed the landscape when it comes to infections and the potential risk of endocarditis, or has it changed it?
The funny thing is the common use of kind of routine antibiotics. The only thing it'll really do to a patient like this is if the patient has endocarditis, and there's two kinds of endocarditis to really worry about. There's acute bacterial endocarditis, which just means that it happens suddenly. And then there's subacute bacterial endocarditis, which is the kind of endocarditis that we saw for years and years. And that was the more traditional endocarditis. Turns out that the latter, the subacute bacterial endocarditis, could be masked by the use of routine normal antibiotics, where the fever could go away for a while, and then the doctor and the patient and the families will think, all right, the patient's getting better. But then a week or two later, the patient's sick again.
Okay. All right. So how does it present? So somebody, that this is a diagnosis. So how does it usually present?
Usually endocarditis presents in the setting of what doctors will call a fever of unknown origin. So the person shows up with a fever and doesn't really have any other obvious reason for the fever. They do a quick inspection, they look over things, they're not finding anything that's obvious. And then other symptoms will go along with the fever that the patient will describe to the doctors, and it can be that they're having trouble breathing, they could be having some chest pains, they could be having fatigue, weight loss, and that's at the onset of the illness.
Okay. How about the workup? So if somebody does, so what you're describing is something that, a fever and not feeling well, and some of these variety of symptoms are commonly shared with other diseases, right? I mean, it could be, it's not necessarily endocarditis that you have that. You could have the common flu, you could have a lot of other things, but what's the workup?
Well, the workup, what happens is that if the patient shows up like this, and they may show up in the office, they may show up in urgent care, they may show up at minute clinic. I mean, there's a variety of places where these patients will seek medical attention. And the workup, well, first of all, is that ideally that the doctor or other clinician that's evaluating the patient is able to do a physical exam. And a physical exam is something that is, hammered into us from the very beginning of our training.
Yep.
And really important to get that done properly. So this is why the doctor has a stethoscope. Doctor has a stethoscope. We've been having them since the beginning of modern medicine. Yep. And you use the stethoscope to listen to the heart to see if the heart has anything abnormal as far as what we call murmurs, which are sounds that you don't normally hear when you listen to the heart.
Okay.
And so if there's a fever and a murmur, then you got to start worrying, could the two be connected? And some murmurs are benign. And sometimes a patient will say, oh yeah, I've had that murmur since I had my physical exam for football practice as a teenager. But the benign murmur may end up being something not so benign and could then become infected because of endocarditis.
Okay. How about skin lesions? Do you see patients that come in that have some skin lesions or something other than the murmur?
Yes. So sometimes you can actually see effects of the endocarditis. And the way I'll explain it to patients is that when the infection gets on the valve can't get rid of the infection, even though the infection is in the middle of the bloodstream, because of the high velocity of the blood flow. Okay. And the immune system can't get to it. So it's kind of like there's an infection that's right there in front of the immune system, but it can't get to it. And when it can't get to it, then these hormones and other chemicals end up getting spread through the bloodstream from the valve, and then they get stuck in different points all the way at the end of the circulation, kind of like you threw a Molotov cocktail all the way in very smallest street. Yeah. And so sometimes the Molotov cocktail is a dud. It doesn't do anything. But other times it can do something. And when it does something, then you'll see a rash on the patient's fingertips or toes or on the small of the foot. Or what would be more worrisome is instead of the little blood vessels of the hands or the feet, it's the little blood vessels in the brain or the kidney or the spleen. And then the patient doesn't have a rash. Instead, they have other complications.
Right. In those cases, like you pointed out, they have strokes or they have neurological symptoms, or they start having organ dysfunction. And the kidneys are not the only ones that get affected. Anything that's connected to the arterial tree, meaning the liver, the gut, muscle too, can get affected by this, right?
Absolutely. And so a lot of unusual things can happen. And sometimes when endocarditis gets discovered by the doctors, it's because they weren't thinking about the heart, but they found something else. So like the person comes in and has trouble speaking and they get a CAT scan and they think it's a stroke, and then they get an MRI and they begin to realize this is not a typical stroke, this is something else. And then they start backing up and they realize, uh-oh, this is endocarditis.
Okay, so those are lesions, or that's endocarditis that happens on the left side of the heart, which is basically the one that's facing the arterial circulation of the body. But how about it? How do you see patients presenting with endocarditis that's on the right side of the heart? Because one of the discriminating factors between an IV drug abuser and those that are other folks is typically the fact that most IV drug abusers get lesions on the right side of the heart, and they present totally different, right?
Correct. They actually have a very different presentation. They usually come in faster. They usually come in sicker, meaning that they have a high temperature, and they usually have a lot of complaints in their lungs. And some of the descriptions that doctors have harken back to the days of almost like Romantic period in Shakespeare and the American Revolution or whatever.
Sir William Osler.
Right, exactly. And so they'll sit there and they'll describe these things. And they'll say, look at the x-ray. It looks like it has cannonball lesions.
Yep.
And so every doctor learns about cannonball lesions, even though none of us really know what a cannonball looks like anymore, unless we watch a cartoon.
Right.
And the patient will get a routine x-ray, which is a $50 test. Can be done anywhere. And in the x-ray, the radiologist will see these spots on the lung that are all really nice circles. And those circles are actually collections of infection that came from the right side of the heart and have not gotten into the left side of the heart, which can lead to a lot further complications. Interestingly, the right side of the heart is much more forgiving when it gets an infection. So some of these patients can suffer for quite some time before they actually show up.
Yeah, and when they show up, it's the same thing. They show up with a murmur, they're sick, they got fever, but the fact that you have a history of somebody who's a drug user or has been using non-sterile needles to inject themselves, that's usually the first sign of it. How about diabetics? Diabetics that use needle to inject themselves, the insulin-dependent diabetics. How does that work out in terms of the risk of their endocarditis?
That's a good question. Fortunately, the use of self-administration of insulin by patients is not a risk factor for endocarditis. They don't need to be concerned about introducing some sort of an infection when they're administering insulin.
How about their immunosuppressant? Aren't they a little bit more immunosuppressant than the when you look at other folks? Isn't that also a risk factor?
It could be a risk factor in certain types of endocarditis, the subacute type, which we can see with people when they kind of been sick for more than 3 or 4 weeks. Diabetes can be what we call an independent risk factor. It turns out that when sugars are running higher, that the actual presence of high sugar can make the immune system sluggish and unable to respond quickly to the presence of bacteria in the blood.
Okay. So let's move on to when you look at valves, there are people that have their own valves, right? The native valves, and then there's people that have had valve procedures. Okay. So
Right.
is there a different definition for each one of them, or is it just called endocarditis?
That's a good question in the sense that the definitions are there, and confusingly, the definitions over the last 20 years have been slightly changed as sort of researchers as well as clinicians, the doctors that take care of patients in the hospital, try and come up with a better, more accurate way to describe them. As far as the issues with the endocarditis, the bacteria that when they attack the native valves, the normal valves, that is a very different illness than if it attacks a valve that had been put in by a surgeon or a cardiologist to replace a valve that had previously not been working.
Okay.
So that's what we call prosthetic valve endocarditis.
So what are the common bacteria, germs, or bugs that infect the native valves if you've never had open heart surgery, your own valves?
So if the patient has never had any kind of cardiac intervention, then the common are going to be what we call gram-positive organisms, going to be a strep infection. Strep, not the kind of strep that causes strep throat, but instead we call it viridin streptococci, which refers to the kind of strep that live in a person's mouth. And then the other one will be staph, which we call Staphylococcus aureus. And depending on the research study and the population looked at, they're kind of close in the number that they are when it comes to the cause of native valve endocarditis.
How about what are the bugs that you could that develop prosthetic valve endocarditis? So the ones that are caused on valves that have already been replaced by a surgeon or a cardiologist.
Sure. So then with prosthetic valve endocarditis, what happens is the list gets a little longer, a little more complicated, if you will, because you still have native valve endocarditis, so things like the viridin streptococci or like staph, but you can also have bacteria that we see in urinary tract infections, like something called Enterococcus. And Enterococcus, when it goes in the bloodstream, if you
Hello? Cedric, you're cutting up a little bit. Hello?
So the doctors have to be very cautious about that, but it's not a. Gonzo?
Yeah, you're here? I hear you.
There we go.
Yeah, you've been cutting in and out a little bit. So, but just continue. Can you hear me?
Yeah, so I can hear you now. So,
yeah,
I was saying, like with Enterococcus, that's something we don't usually see with native valve endocarditis. We can,
okay.
But when we see it with prosthetic valve endocarditis, that can be a very serious problem.
Okay. We jumped on the diagnosis, but I didn't really have an opportunity to ask you, what's the workup usually consist of?
Well, what will happen is endocarditis is a definite example of the whole team approach. So the doctors have to examine the patient, get blood cultured, obviously talk to the patient, and then they have to get a sonogram of the heart something called an echocardiogram. And then there's several ways to get the echocardiogram because of the shape of the heart and where it's located in the human body. There's ways of looking at the heart on the front end and also on the back end. And that can lead to a further workup as the doctors continue to try and figure it out.
Perfect. Okay. Tell the listeners what a vegetation means, because that's another common term thrown around when we're seeing patients that have endocarditis.
Right. So vegetation means that on the valve itself, there is now a growth that actually resembles sort of a piece of broccoli or a piece of cauliflower. And back in the 19th century, they described it as a vegetation because everybody worked on the farm. But back then they were describing it at autopsy. They were finding it on the valve.
Yeah. And that's a good point, because, you know, it does look, when you look at it inside, it looks like a grapes all clustered together, or like the head of a cauliflower or some broccoli, basically fungating like that into the heart.
Right. And so, you know, using the word vegetation was an obvious description 130 years ago.
So what's the therapy? What's the therapy for these? Once you have endocarditis, how do you manage it? What's the therapy for it?
Well, the therapy for endocarditis also has to be a team-based approach, because they'll frequently call the infectious disease doctor to make sure the patient is on antibiotics. The antibiotics must be given for a long period of time, typically between 4 and 6 weeks. And then when the antibiotics are given, they have to be given intravenously, which for patients means they have to have an IV, and it has to be a drip, and it has to be given in high concentration.
Okay. And so when is it that you have to consider that you need to send somebody to surgery, have somebody be evaluated by a heart surgeon to manage the condition?
So the most interesting thing about that question is that ideally, if the patient needs surgery, they'll get the surgery before anything bad happens.
Right.
But usually the recommendation will be, when bad things have happened, they need to be considered for surgery.
Right.
So you need this crystal ball to be able to say, all right, this is a large vegetation. I'm worried that it's going to break off. I'm worried that the vegetation is destroying the valve, that the patient's heart can no longer pump properly. So it's called heart failure. And then there are other things that the infection can do where it can actually erode through the heart and make the electricity in the heart not work right. So that's called heart block, where the heart isn't actually even able to conduct. And those are all emergencies.
No, and so, you know, and you raised a really good point that I want to make sure the listeners understand. The way that we handle things at the Fort Worth Valve Program is that a person that has a history or a diagnosis of endocarditis gets the consult of a cardiac surgeon, not necessarily because we're going to operate on somebody, but because as part of the multidisciplinary approach that we have, we've got multiple specialists looking at it. We got Cedric from the infectious disease, and then me from the surgery aspect looking at it, so that if we do have to do something, it's not done late when consequences are bad, and then the outcome is worse because the patient's decompensated, or they're in heart failure, or they've now had a stroke, right?
Correct. And in fact, this is sort of a newer way of thinking, because 25 years ago, the idea was, we need to wait until there's a certain better time, and we need to, delay the surgery. And now lots of studies have shown that if the cardiac surgeon's involved and the cardiac surgeon is able to do the surgery, the patient will do better if the surgery is done sooner.
Okay. I'm going to ask you a question, and I want you to tell me the truth. Who's your favorite cardiac surgeon to handle endocarditis?
That's an easy one. Definitely Gonzo. Gonzo and his team are fantastic, and I do mean that sincerely, because I've worked with many cardiac surgeons over the years, and the interesting thing about the valve surgery is all of my cardiac surgery friends tell me the valve surgery, when it's an infected valve, can be very challenging.
They are. Okay, so how can you prevent endocarditis from happening, Cedric?
So prevention is a very interesting, sort of, initially you'd think easy topic. Unfortunately, it's gotten really complicated, because 25 years ago, when there was these additional observations of endocarditis, somebody had a heart murmur, or somebody had mitral valve prolapse, which is a common valve condition that may or may not be important. Then they were all getting antibiotics for prophylaxis at the time of any dental procedure. And so the dentist would have to give antibiotics. And then
so what do we do now? Do we still recommend patients to have antibiotics before dental procedures?
Well, the funny thing is that the world's experts have done studies on tens of thousands or even hundreds of thousands of patient lives and are backing off on recommendations for prophylaxis, because it turns out that when they were recommending everybody to prophylax, dentists were getting sued for endocarditis, and nobody was actually proving that patients' endocarditis was prevented when the dentist gave them a common antibiotic.
So let me ask you a question. So then how about this, because this is a common thing that I've seen heart surgeons do. And I actually asked a question a few years ago to one of the dentists, was that, does everybody who has caries or cavities should have their teeth removed before they have valve surgery and treated with dental resections? Is that still the same case, or has it changed?
Well, so once again, that becomes more of a sort of a surgeon-specific discussion, because the data, the other way that when doctors work together, there's surgeons and then there's non-surgeons who are trained in medicine, and we always look at patients a little differently.
Right.
And the funny thing is I'm a medicine doctor, and when I talk to a surgeons, when they get trained, and they get some of the best training in the world, but they get trained based on sometimes almost like legends and horror stories.
Absolutely.
We call it surgical lore.
Yeah.
So surgical lore is like, well, this patient has horrible teeth. I'm about to do a life-saving valve surgery. If their life-saving valve surgery gets infected, they need a reoperation in 6 weeks. That's probably got such a high chance of them dying, the surgeon shouldn't even do the surgery to begin with.
Right.
So then you're like, well, Mr. So-and-so or Mrs. So-and-so, I'm sorry, but the teeth that you have need to go. And then what's interesting is Medicare rules have made that complicated, because Medicare won't pay for teeth to be removed in the hospital.
Right.
So then the doctor
dentist on call. So what do you do now?
What do you do? Yeah. And so then you're like, all right, do I have to send this patient to a medical center where they have inpatient dentistry so I can remove their teeth? And the conversation can sometimes be almost absurd, because the teeth are part of the body, but Medicare won't pay for the teeth to be removed.
Well, Cedric, listen, I think that was a really good summary and overview of bacterial endocarditis and how do we deal with it on a day in and day out. Thank you so much for taking the time. If I get to meet your kids, I'm going to tell them, dude, your dad is one of the coolest cats that I know out there. So thanks again for doing this for us. I really do appreciate you being online.
Thank you so much, Gonzo. It was a pleasure, and it's always good working with you. So keep up the good work.
Same here, and I'll see you around the hospital. And for the listeners, thank you so much for tuning in. This is Dr. Gonzo with Talking Points, and we just listened to Dr. Cedric Spak from Tarrant County Infectious Disease. If you want to know a little bit more about him and the work that he does, look down on the comments section in the description of the audio, and you'll find all his contact information if you want to ask him questions, or leave comments down in the bottom of the podcast, and we'll make sure that Cedric can address them. Again, thanks for listening, and see you next week.